All right. Thanks for joining us. We have Dr. Carol Gilbert on today, Assistant Professor at the University of Nebraska Medical Center, College of Public Health, and Senior Data Health Analyst at City Match, and long time friend and faculty member of the training course and PPOR, as you'll find out with colleague Bill Sappenfield. We're excited to have her. She has very limited hours, so I'm very grateful for her spending them with us and today and the next couple of weeks. So welcome, and I'll hand it over to Carol.
I will share my screen. Nice to see all of you. Now, does that look right?
Yes.
Okay.
And we can see you too.
Switch which screen it goes on. Well, all right. So perinatal periods of risk. Bill and I have traded back and forth on this presentation. So there's some of my slides and some of his slides. He's been doing this forever. And I've been doing this almost as long, pretty close to forever. And I've worked with a lot of communities across the country, so I'm happy to do that, actually, to work with you guys if you're doing PPOR. So Bill put these questions in, and maybe you can do this with hand raising, although I can't see all of your hands. But the first question is, have you worked on a mortality study, an infant mortality study, or a project? Is that part of your job, or has it been in the past? Can you do hand raising? Oh, there's somebody figured out the hand raising.
Yeah, we
So
have a
just
couple.
a few. I'll give another minute here because it takes a while to find that button, right? I love the little sound effect that goes along with it. So there are people. Okay.
11.
We're not going to get as sophisticated as all these levels, but still, oh, this is very helpful. So lots of experience, at least with infant mortality being an issue that's important with you guys. Have you worked on PPOR? So you got to put all your hands down again and raise them off again if you. Or maybe we could, well, I can't do it with video because some people don't have it on. So just a couple with them that have done PPOR. Okay. Well, even if you've done it, you might learn a thing or two here, or help someone do it. There's a down. That's a good one.
And Tanaya said it's been a long time, so a good refresher for her.
Yeah. So one of the important things to know about PPOR is that it is part, the analysis part that we'll be talking about today is really just part of PPOR. And it's the part that you as EPIs would be most having a huge role in, but it's important to realize that the whole process is similar to the femur process and any other MCH, any process that gets things done. You have to have these other stages as well. And we start with readiness, and we will talk about that some in this little webinar. Community readiness is a part of it. Like, does your community really want this done? Do you have a plan for how you're going to use this data? Is there a committee that's going to take this data on and understand it and go back and forth with the EPIs? In my experience, PPOR never really works unless you've got that community group. That an EPI sitting and doing it on the computer and making a report is not going to make things happen. You need some back and forth questions about how you're going to group things, who you're going to target, that kind of thing is important. So then you do the analysis, and then you maybe develop or modify plans to figure out what you're going to do about the problems that come to light, or the change what you're doing, and then implement them. That's stage 4. And stage 5 is monitoring and evaluation, and you can use PPOR for that too. There's a lot of communities that make PPOR just sort of a part of surveillance, and so they can watch things go up and down and watch things change as they implement. And it takes a long time to implement stuff. And also to be most things, it seems like we have to keep on pushing, or they'll go backwards. So a lot of times these programs outlive the epidemiologists, not outlive their lives, actual lives, but outlive their time at the health department or in the department, because epis tend to move a lot, and this PPOR sort of process takes a long time. And then one of the things that Magna Peck added to the PPOR is really the step of sustaining the stakeholder investment by feeding the data back to the community, saying, look what we did, and celebrating it. And that's an important part of data too, data communication issue. So that's going to be all that we talk about all the phases. But we really are going to do the preparation, and the phase 1 and the phase 2 analysis are all part of analysis. And a little bit of readiness will get in there. So preparation means getting the data, doing the descriptive statistics, and checking the data quality. We are going to talk about specifically what that means. Phase 1 analysis is to figure out which populations and risk periods have the most excess mortality in your community. Then we'll talk about what excess mortality means. It's a different thing from just mortality. And then phase 2 analysis, which is also necessary and which a lot of people skip. So I hope you'll come back in 2 weeks to watch the phase 2. That's the part where you figure out why it happened, and using vital records data and any data source that you have to figure out why those gaps are there. And because that's how you plan what to do about them. So the approach was built on prior methods that already existed. People in the World Health Organization were using this at the national level, and for huge national hospitals, they were dividing babies' deaths up into categories based on their age at death and their weight at birth. And PPOR uses this method because it works. The people back in the 60s and 70s and 80s were doing this because the age at death and the weight at birth were predictors to them of what was going on, or they helped them understand what they should do to fix the problems. So this is the first dimension, age at death. And this is sort of a good review too, that of what the definitions are, and the definitions, especially in fetal deaths, as they're changing. Spontaneous abortion used to be pretty clearly 13 weeks. Now it's partly with the abortion laws that are changing, and also the survivability is going down. The viability age is the babies can survive at 22 weeks in some fairly large numbers now, as opposed to 24 weeks. What it used to be called an early fetal death was less than 24 weeks. Recording of fetal deaths isn't required in most states until 20 weeks. So we know a lot less about those fetal deaths that occur before 20 weeks because the data is not collected everywhere. And there's some efforts to learn more about those fetal deaths. But then late fetal death was after 24 weeks. Everybody knows, I think, that a fetal death is a death that occurs before labor and delivery. So the baby has not been born yet. It dies. It's delivered and it's already deceased. And sometimes the death can occur well before labor and delivery, so that the delivery date doesn't really mean the gestational age at death, but all we know is the delivery date. We don't, the gestational age is kind of mushy there. So in afterbirth, the first week is an important marker, but we use 4 weeks. We use the neonatal period as a period where a lot of deaths occur. If a baby's going to die, a lot of times it happens in the first day, even, or the first week, or the first 4 weeks. And then there's a whole different category if they survive 4 weeks, and die in the post-neonatal period. The causes are quite different. Usually the baby has gone home, and the health causes are different. The second dimension is birth weight, and this little chart shows neonatal in Washington report is defined as within the first 27 days of life. That's right. The 4 weeks is 4 weeks is 28 days. So 28 and more is post-neonatal. You're right. 27 days is the neonatal. So birth weight has categories here. 500 grams or less are excluded from PPOR analysis. So we'll go into a little more about why. It's not, there are some babies who are born at 500 grams or less, and some who survive, some who survive, I'm not sure how many. Then less than 3.3 pounds or 1,500 grams is called very low birth weight, and that's an important category for PPOR. Low birth weight is the more commonly used category, and that's less than 5.5 pounds or 2,400 grams. A baby that weighs about 4,500 grams is about a 10-pound baby. So most of this chart where the light blue is kind of an unlikely event. Most babies are not in that light blue area. Go a little bit. This is how the World Health Organization periods of risk map looked. They used those periods, fetal deaths, early neonatal, that'd be before 1 week, late neonatal, 1 week to 4 weeks, and then post neonatal up to 4 weeks. And then these birth weight categories, 500 grams to almost to 1,000 and 1,000 to 1,500, like that. So there was 16 different categories. And they would look and tally the deaths that were in those categories and say, this hospital has a problem in this area, in a particular area. It would help guide their quality improvement efforts. In PPOR, back in the late 90s, they took the World Health Organization and used cluster analysis to figure out which of the periods could be combined together to make a simpler map. Simple is good, but it's also because the numbers were too small in US cities to divide them up into 16 categories. Does PPOR look into macrosomia? Macrosomia is pretty rare, and so it wouldn't be part of phase 1 analysis. It could be looked at if you found that you had a problem in fetal deaths, and that was one of the risk factors that you can look at, then that would bring up macrosomia. And it's nice that I can see some of these. I don't see all of them though, so Ashley, you let me know if I miss one. So anyway, the 16 boxes are combined into 4 boxes, and you can see that it goes the top row, then the 8 blue boxes include fetal deaths. They include all the periods of death. They include babies. They exclude the less than 500 gram babies. They include up to 1,500 grams. So this blue box combined is the very low birth weight births. And then the larger fetal deaths is the pink 2 boxes, and that is, we also exclude fetal deaths that are less than 24 weeks. So the 20, 21, 22, 23 week fetal deaths are excluded even if they're reported in a community. And the neonatal deaths that are larger when they're born are this yellow box. The neonatal deaths are in the first month, and then the post-neonatal deaths are the 2 green boxes. Then those are the larger babies that could survive and don't. They have survived the first month and gone home usually from the hospital. Not always. Does the order of late and early neonatal correct in the visual? Oh, you're right. It's switched. Just a typo. No worry. Good point, though. So this is what they look like when they're combined. I just wanted you to know, who's in these boxes. And what we'll do is tally the deaths. We'll put, just like the World Health Organization people did, we'll count the babies that belong in each of the boxes, and that becomes the numerator for a rate. And we'll do that. A lot of people, if you're teaching this and explaining this, people don't understand that. So you guys do. The cool thing about this, and that the cluster analysis of combining the ones was based on the cause of death, for the baby and also the maternal risk factors. It was clustered on both of those things. And what that means is that each box has a set of causes that are really strongly associated with that box. And that it's nice because if you find that one box is important and other boxes aren't, you can focus on those boxes and on those causes. So you focus your efforts. You don't have to take care of all the causes, all the possible causes of infant mortality. One of the things that people said when they first started using PPOR, city health department, county health departments were like, we try to make people understand that infant mortality is not one thing. It's a whole bunch of things that we have to work on. So it helps a lot to know which of the things we need to focus on because there's so many of them. And there's a lot of preconceptions about what we should be working on. And it's important to know really what is the root cause of this particular community's infant mortality problem. So what do we need to do if we want to start doing PPOR? We need those people. Remember I said nothing works if it's just the epi working alone in their office. So we need leaders and champions who are ready to work on this. And it's good if it's an interdisciplinary community collaborator team, people who aren't just from a hospital or something like that. People who know about social determinants and people who maybe serve communities with social determinant efforts. We need that data. We need the raw data, or else somebody who's going to do it for you. Getting access to raw data is getting harder and harder in the past few years. And some places that are local health departments are relying on states or even state people who are MCH EPIs sometimes can't get the raw data and need to get summarized data from their state vital records department. There's all kinds of trouble. Usually you can get it, but it takes a while. You have to fill out a lot of forms and sign a lot of agreements. So, and you also need to have enough deaths to get stable estimates. And we have a rule of thumb here that it has to be at least 60 feto-infant deaths, and that roughly translates to about 60 infant deaths in at most 5 years. So you can combine years, and you can get a geography possibly too that can help you have a bigger number. But this is still math, and we still have problems with confidence intervals being too wide if we don't have enough numbers. So remember the 3 steps: the preparation, the phase 1 analysis, and the phase 2 analysis. The first part of preparation is often to figure out what study population you want. Do you want your city? Do you want a county? Do you want a group of counties? If you're a small county, you might need a group of them. So, but you need to work on that. And we use the place where the mother lived at the time of the baby's birth. And this gets complicated because you've got death files and birth files and a place where the baby was born. The hospital where the baby was born is not what we use. We use the place where the mother lived at the time that the baby was born, not at the time of the death either. So the steps of data preparation is getting that data, preparing and assessing data quality. This is a step you do not want to skip. And then, cutting back by the less than 500 grams and the less than 24 weeks, and then assessing the study sample size and check and see if you need to make your geography bigger or add more years to your data if you don't have enough numbers. And I think Bill didn't put slides in here for this, but the reason why we don't use deaths that are less than 500 grams, or in the case of fetal deaths that are less than 24 weeks at gestation at the time of delivery, is because there is variation in reporting. It often happens that you'll have one hospital or one county where they are typically reporting all those fetal deaths. Fetal deaths is especially a problem. A few states, 5 states, I think, require reporting of all fetal deaths, but they don't really report all fetal deaths. They are much better at reporting the later fetal deaths. And I did some research on this for my dissertation and really found that still, even 20, 30 years after this initial data was found, that we do not report fetal deaths consistently across the country. And the name of the game is comparison. So if we're comparing, yeah, you can confirm there's variation on data quality by hospital. Yes, I think that's true. Yeah, but it's good to hear those stories. Maybe we get time for you to tell the story, or you can put it into chat. Um, because people doubt that. They think that if there's a law, that everybody should follow the law. And doctors are kind of famous for having their own opinions and their own processes. So we do not report consistently. And if you're comparing from one hospital to another, and say if mostly Black people deliver at one hospital and mostly white people deliver at another hospital, you can get a disparity that's just due to reporting differences. And that's what we don't want. And so that's why we avoid the issue by just restricting the population according to birth weight and age at death. We can talk about that more. Happy to answer questions about that. So we need 3 vital records data files to do this. We need the live birth files, get our denominators from those, and also do the risk factor analyses. The infant death certificate files are linked to live birth certificate files, and then we need separately the fetal death files. So that's the populations are the live births plus the fetal deaths. And then the infant deaths is the subset of the live births. 3 different files for each year that you want to do. And this is sort of a schematic of what it looks like, the linkage, and then the fetal deaths are sort of stacked on to those. And the fetal deaths, of course, the death information is in the same certificate because birth and death happened at the same time. And oh, yes, an important note that spontaneous and induced abortions are not included, and spontaneous abortions are what we used to call miscarriages, and they're just another kind of fetal death, but they're too small to be reported and included. But induced abortions are not included. That's a whole separate surveillance system. And since it's not so much related to maternal health, but rather maternal choices in most cases, it's not super important to include that unless that's a particular outcome you're interested in. So why does PPOR include fetal deaths? You'll find that the data quality is much poorer for fetal deaths, and it makes it much more complicated to have another data file to use. But it's important. The parents, first of all, it's a grief. It's a loss, a real loss. And there's evidence to suggest that a lot of those fetal deaths really are preventable. It used to feel, yes, fetal deaths are stillbirths. If you don't include, this is part of the definitions, but fetal death is usually any of those. They used to divide it carefully into stillbirths are over 24 weeks or over 20 weeks. And then, but that's not so much. In states where let's see if I can read that one. States where abortion is very restricted, figuring out induced abortions is simply not possible sometimes. Right. They don't, I think the surveillance is just collected at the state level anyway. I don't think they record where the mom lived, but where the abortion happened. So you wouldn't get resident information from abortion data. So that would be, yeah, not as meaningful. But boy, it is a big question now. So it's important to keep it in mind. Like infant deaths, fetal deaths can be an indicator of a health problem, right? An infant death is like a canary in the coal mine. Infant mortality rates tell you about the health of the community. And so fetal deaths also do. Fetal deaths help tell about the health of moms and how communities are supporting moms. And also, there are a lot of them. There are really more fetal deaths than infant deaths. If you include all the fetal deaths as those 5 states do, there's about 7 times as many fetal deaths as infant deaths. It's less. It's about equal if you include the 20-week or more fetal deaths. That's clear. This is sort of a schematic of the linked file. So for each row is a baby. It tells where the mom lived when the baby was born. It gives you birth weight and maternal age and a bunch of more demographics and a whole bunch of more factors about the birth and the mom's health. And then the death certificate, we get things off of that death certificate are mainly the age at death and the cause of death. And we typically use the underlying cause of death, which is obtained from the CDC algorithm that takes into account all the causes of death that the doctor or coroner writes on the death certificate. But that's the main idea of what the linked infant death file looks like. So quality checks, I said, don't skip those. And as we would do with any analysis, if we had time, but you might think you're skipping it because sure, these are data sets that people use all the time. We report the national numbers. Of course, all these things are right, but they're not. So you have to check frequencies. Just run frequency tables and include the missing value. Include the missing values. You don't always know what is coded as missing. And you need to know that. You also need to know the code book. What are the variable definitions and the value labels? Understand the codes for missing data especially. And check for implausible data. There sometimes still are implausible amounts, like a 600-gram 36-week baby. This kind of thing happens. I've seen it happen where the instead of grams, they put in pounds and ounces. So it turned into a 6.2 gram baby. And that, you can fix those things, but they're in there. You don't want them to mess your analysis up. And also really know your data set. Learn where the data elements come from. On the birth certificate, the mom fills out some things. You might want to know things like what happens if the mom doesn't speak English, who fills it out. There are things that are really, depending on who your focus population is, who your priority population is, you might want to know things like that. But which part of the birth certificate data comes from prenatal care records? Which part comes from the hospitalization records? And hospitals don't all do these the same way. So this is something you might want to learn about from your hospitals, depending on how many hospitals you have, and you want to develop good relationships and invite them on your committees and learn about these things. Also, you need to determine which variable version is appropriate for your use. We do use the place where the mother lived at the time of the delivery, and it's important to probably start with the least aggregated versions of some of the variables, especially demographic variables, especially race. Would be an important one to disaggregate as much as possible and then thoughtfully aggregate. So if you have it's okay if the numbers are small while you're getting to know your data set and checking data quality. But you might find out important things like all the birth weights are missing on people who are born, who went to this birthing center, or it's something that, and this is a special Native American birthing center and they weren't recording mother's education. Well, all those people are going to be thrown out of parts of our analysis if we don't know these things. It'll mess us up. So you need to know these things. Use some little details here. Use the obstetric estimate of gestation, and that's sort of switched over from last menstrual period. And usually there's a variable for that that switches into last menstrual period if the obstetrical estimate is missing or wrong or invalid or something. Use calculated values for some variables if it's already been validated by somebody. And this you can check with your state vital records. Do they have a good valid variable for gestational age so you don't have to calculate it? Number of prenatal care visits, that sort of thing. Yeah, short interpregnancy interval is another one because birth spacing is a risk factor. So remember that minimum number, at least 60 deaths for each population being studied. So if you're interested in Native Americans, you need to look at the numbers from Native Americans. If that's the population you're most interested in, those numbers will be small. So you might need to combine years to get adequate numbers of deaths. And yeah, our guideline is not to combine more than 5 years. Guidelines are made to be broken, but that is, there's reasons for that guideline. Of course, you can't look at trends within the years that you combine, and that's important. You can combine geographical areas. Yeah, but it's helpful if there are some systems and factors that are something in common that this um, community means something has something in common. 60 deaths is an important thing because the confidence intervals get so large. So this is just a Poisson confidence intervals for the same rate, but the smaller numbers of samples, you've got just enormous confidence intervals, so much that the disparities will mean nothing. You know, the differences are not really measurable when you have large confidence intervals. They picked the 60 deaths based on each period of risk would have at least 10 deaths in it. And so the confidence interval is huge. Anyway, 60 deaths is a very small number. I really never encourage people to break that rule. I mean, really, you should use more than 60 deaths if you can to make statistical decisions. So data preparation means getting the data, getting that IRB approval. If you want to publish anything, you need that, and you might need it anyway, even without publishing. Preparing data is significant. It's a lot of time to get to know that data set too. If you aren't knowing it already, based on your past job, that's a time thing that you'll want to take into account. Whether you've got staff that have used vital records before. But yeah, but you need to do that data preparation and quality checking step. Now, for phase two analysis, these are just the quick steps, calculating numbers and rates in each period, make that PPOR map, they call it, select reference populations, and then calculate excess mortality. And that's what we're going to do right now. But this is a good place to stop. I know people have been asking questions all along, but if anybody has questions right now, this would be a good moment for that. Otherwise, I will just keep watching the chat, and Ashley will as well. Okay,
I had
can I?
a couple questions. When when you were talking about spontaneous abortions, you said they were too small to include. Were you talking about the actual birth weight, or are there too few of them, or?
Oh, they would be mostly spontaneous abortions. Well, the ones that Bill is talking about in this slide are the ones that are not recorded because they're less than
Right.
20
Okay.
weeks. That's all. There's no special rule that says you can't include them in vital records. If they're more than 20 weeks, they should still get counted as a fetal death and get a death certificate. Doesn't mean they always are, but the very early ones, often the mom doesn't even know she's pregnant. It's a
Sure.
we don't really know how many they are, those very early.
And you said don't aggregate more than 5 years because there are changes in medical practices. That's just based on your experience. Could you elaborate on that a little bit? That's based on your
Yeah,
experience, what you've
I think
seen.
part of that comes from Title V cycles, um, that are 5 years. It's really a rule of thumb. And if you have an issue that you want to combine more years than that, you would probably want to check and see if medical practices have changed. It is that is really there are people who have used 10 years before, so it's not a hard and fast rule.
Thank you.
And Tanaya had a question as well.
Yes, I was trying to find the audio button. So
Okay.
you mentioned, so the next, you're setting us up so we can actually calculate excess mortality.
You
Is
bet.
that okay? Okay, because I was like,
Yeah, that's the next
like, did I
thing.
miss something? Okay,
So
yeah, because
far, this has all been just
yeah,
getting ready.
because I did put the link to our state report. And it's just a sheet of numbers, and we have been wondering, like, should we take this down? We do update it every year. And it has fetal death, infant death, and the um neonatal, sorry, I missed this, got post neonatal. Yeah, we go through all of the time periods. And the focus is on trying to highlight the differences in the rates, but I think that if we could add to estimating excessive mortality to this, we're just restructuring it actually, but yeah, always looking for opportunities to improve what we're doing. Thank you.
Yeah, that might, PPOR might be something that would help you in that case. Yeah. It points to clear what you should do kind of things. Somebody put in, oh, Fabricia, is that how you say your name? Fa is easier. In my state, reporting stillbirth is optional, which leads to serious underreporting of fetal deaths. I think that every state
I should
has
bring
a
mine, my
law.
extra, and add it to your stash.
Every state has a law that requires reporting of stillbirths. And so your state probably has that law. At less than 20 weeks, it's optional. And there's a couple of states yet that still have birth weight restrictions on that instead. So it's less than 500 grams. It's optional. But there is underreporting. Maybe somebody thinks it's optional when it's really not. There, so yes, it is the best way to account for that in the analysis is to that I know of is to use those cutoffs. The less than 500 grams, less than 24 weeks cutoff is for fetal deaths. But you should check your state laws. I just Googled them and I didn't find a single state optional under certain circumstances. Yeah, I think every state has a law, but still they don't necessarily follow them, and it is a problem. There really is underreporting. Maybe the next time I can show you my analysis it was from 2014-16, but I don't think it's changed much. So gone to calculating the numbers and rates. So there's an example. First, just to know, this is sorting deaths into the categories. So we have an infant that weighed 2,450 grams at birth and died at 22 days. Which risk period is that infant going to be sorted into? A second here, but neonatal, yeah. So the less than the 2,400 gram means that it's going to be in the bottom row, and the 22 days means it's going to be in the yellow box. So it was actually born alive. That's an infant death. Okay, I think there's another example here. Yeah. Fetal death delivered at 33 weeks gestation and weighing 1,900 grams. Where's that one going to go? Pink. Yeah, that's right. So fetal death, because it's a fetal death, it's either going to be in blue or pink, and it is more than 1,500 grams. So it goes in the pink box. Thanks for putting in those answers. That's great. Baby born alive at 23 weeks gestation, weighing 640 grams, and died at 0 days. $640 grams means it will be included in the PPOR. It's not less than 500, but it is less than 1,500, so it's going to be in the top row. And since it's born alive, we don't have to exclude it for being less than 24 weeks. So all the born alive babies get included, no matter what their gestational age is at birth. So yes, blue box. One more, I think. The fetal death at 23 weeks gestation, weighing 640 grams. And I kind of gave that one away. That's the one that's not included at all because it's less than 24 weeks and it's a fetal death. Don't have to exclude those for infant deaths, but we do for fetal deaths because reporting is so inconsistent. Okay, so what we end up doing is counting. So all those babies get sorted into these boxes, and when we count them, we find that we have 97 in the blue box, 48 in the pink box, and the blue box is a mixture of fetal deaths and infant deaths. 44 in the yellow box, 47 in the green box. And all the ones in the yellow and green boxes are only live births. So what do we need to do? Well, yeah, we can add them up and figure out how many fetal deaths and add them up and figure out total deaths. We need to know how many live births. Why? Because we have no idea if this is high rates or low rates. We need to know how many births there are to make rates. And that is very easy. Making a rate for PPOR is the same as making a rate for infant mortality. You take the number of deaths, multiply by 1,000, and divide by that number of that number in the denominator is the population at risk, which includes the fetal deaths and the live births. So it's 23,282. If I go back there, I don't know if I can go back. but you add the live births plus the fetal deaths anyway. So making the rates for each box still gives us really proportionally everything is going to be the same because you divide each box by the number, the same number. The denominator's the same for all of them. And very nice if you're a person who likes order, you can add these up, add the rates up, and they add up to the overall rate, the same as if you added up all the deaths and divided by the number of live births. That's why it's important to combine those 3 vital records files together. Yes, it is.
Some people just get excited with the birth certificate. I was like, well, that's just part of the story. That's live births. You know,
Mhm.
we need to combine fetal and yeah, the infant records.
Yeah,
So
yeah, there's really a lot of them. And even this is
mm-hmm.
with our restrictions, with our taking out the less than 24-week fetal deaths. There are a lot of fetal deaths. And they really do help tell the picture, tell the story of what's going on with the mom's health and the community's health. So now we've got this set of rates, and we're left with another question. How do we know what's good? Is this good or not? Do we have a problem or not? Oh, well, confidence intervals are important here for, actually, that slide doesn't belong in here. I'll come back to that. What we need to do is if we, once we know those rates, we need to know what's wrong. We need to make sorry, I'm getting out of word here. We can compare these. We can compare these for different groups. And this is Urban County. This is actually Douglas County, Nebraska. It used to be that they would do these every year. They would update it with a rolling average and then just publish these. And are we getting better or worse? And you can see that during the 90s, they got better with the green box. Things went way down in the green box, and they stayed down. And this is mostly because of the Back to Sleep program. We also could see that the pink box was holding steady. Since then, the pink box larger stillbirths went up, but you can get sort of an idea of what the causal trends are here. You can compare subpopulations, white versus black. This is pretty telling. You know, we know that there's a disparity in infant mortality rates, and that is pretty much in line with the overall rate. But the PPOR, dividing it into these 4 periods, helps you see where that disparity originates from. And a lot of times people are surprised to see what a difference it is in that blue box. That very low birth weight is really an important part of Black infant mortality. And that's pretty well known, but the public doesn't know it. There's also a disparity in this case. There's a disparity in the green box, a huge disparity, black, white, and green box. And that is a lot of times related to safe sleep, not shaken baby syndrome, but safe sleep infant deaths. Now, since I'm running short of time, I'm just going to give you the analytic exercise so you can practice these yourselves with the answers, so you can always check your work, but I won't have time to do everything.
Carol, I think you have until 2:30 today.
Oh yeah, that's right. I won't
You
run out.
have some time if you'd like it.
Yeah. Well, I think I'll go through first and then
Okay.
let you guys, and so we can go over the exercise if we want to at the end, or we can do questions.
Perfect.
So yeah, when you compare subpopulations like this, it starts the community beginning to ask questions like, if one group can experience such good outcomes, why can't all the groups experience those same good outcomes, right? So this is an important question to ask. And PPOR just uses this question as the basis for excess mortality. And so formalizes this question. And so we're going to go on to finding a reference group and calculating excess mortality. My animations aren't good. So the finding a reference group and calculating excess mortality is what gives us the opportunity gaps. It tells us which risk period and which population are the places where we need to address problems. So selecting a reference population and you calculate the mortality rates and numbers of deaths for that reference population, and then you subtract. That's the simple thing about it. The reference group, though, that is not simple. I mean, it can be, but really it should be thought through with the community. This is going to be our baseline, our goal, the mortality rates that we would accept in our community. And once we find an acceptable population to compare to, our goal is then to have no disparity from that population, except no difference. And we do know that a lot of people use essentially like, who was it? Somebody was Tenai, I think, said that their state was tabulating all the things for all the races, and the goal was to look for disparities. But the fact is that all the groups can usually, I mean, the white group can always improve too. So that's part of the reason to use a reference group. So we ask, which women and infants have the best outcomes? And we assume all the infants should have the same, and all the infants in fetal deaths should have the similar best outcomes to that group. So we choose a comparison group that has already achieved best outcomes, and we compare our study population, our priority population, to that group, calculating excess mortality just with subtraction. The target group or study population minus the reference population. That's the gap. So reference populations they are real populations, real people, and they can be a subgroup from your jurisdiction. They can be also from external, if you're a county health department, they can be your state or a group of states can form the reference population. If you're a state, you can use the national or a group of states. The national reference group is often what people use because it's easier and because data quality problems maybe not. Sometimes we have too small numbers to make our own internal reference group. So some examples of reference groups, white mothers with a bachelor's degree or more. And why would we use that? Because educational attainment is a really good proxy for socioeconomic status that we have in the birth certificate. And why is it such a good proxy for socioeconomic status? Well, we know people with a better education can get better jobs, right? That's part of it. But it also reflects the mom's parents' socioeconomic status. So because they help her get her education, right? So, and that is also closely tied to health. So it's kind of life course socioeconomic status. Education is a good proxy for socioeconomic status when it comes to health. Some in Florida, I think it was Miami-Dade, they got really angry with us for using white moms. They said they use Cuban moms. You can use whatever you want. And they have a large population of Cuban births, and they have good outcomes. Some places want to use Asian mothers because they have the best outcomes. Some places, Louisiana for a long time, was using a Black reference group because people really kind of thought that Black infant mortality had to be different from white infant mortality. And they used the Black group with high education to say, no, you can improve Black infant mortality. You don't need to to just accept things as they are. So using a Black reference group helped a lot. Somebody put in that non-native US moms are healthier than native US moms. You could consider using that is in the birth certificate, whether the mom was born in this country or not. there's a little bit of controversy on that because we're not sure how long it takes people to adopt our bad customs. And all the birth certificate tells you is that whether they were born in this country, so we don't know when they immigrated. So it doesn't work as well. But you could consider it. You could take a look. You could also know, like sometimes there's immigration waves, and you can know like when everybody arrived. So it's a possibility to use whether you're born here or not. So guidelines for a reference group, you have to choose a real easily defined optimal group, and we base it on demographics rather than health characteristics. Like you might be tempted to choose all non-smokers or all people who aren't obese. But we get into those health characteristics later in the analysis. They come in phase 2. So this is a demographic group. And part of the reason for that is because people have to identify with it. You have to be able to say, this group over here already has these good outcomes. And they probably do have some better health behaviors. They probably do have high socioeconomic status based on how we choose the reference group. But we want to choose a reference group that is easily identified in the community and that the community relates to and the community agrees that this is our goal, that we want everybody in our community to reach this same goal. And it's good to have socioeconomic status in there as one of the criteria, because that's, we know that social characteristics affect health a lot. So the national reference group that we started out using in PPOR 20 years ago was US residents age 20 or more, because there's a lot of controversy about teen births having bad outcomes, and it's not so important anymore to use the age criteria. Some people use a high age criteria because it's much more likely to have older moms that have bad birth outcomes. Teen births have gone way down. 13 or more years of education means that she had 1 year post high school. She graduated from high school and did 1 year post. Oftentimes now we use college education, like all 4 years of college, as the educational criterion. But you're free to use whatever you want, anything that's available on Vital Records data set. Another thing that might guide your selection is data quality. If you don't have good recorded data for maternal education to be one of the factors, and half of your fetal deaths don't have maternal education reported, that is really going to mess up your reference group. So you don't want to use maternal education in that case. There are some other imperfect socioeconomic status indicators. Having Medicaid pay for delivery is a possibility. Going by neighborhood, if all your mom's addresses most addresses are well known, so you can identify what census tract they lived in. You can use because we're such a tidally segregated society, you can use the median income for the census tract and try to get at socioeconomic status in that way. There's a comment here from Tanaya again. We argue on whether or not to keep marital status in the reports. And the marital status variable really is a two-part thing now, whether they're married or not, and then if they're not married, whether the dad is on the birth certificate. We find that marital status comes out as an important factor in PPOR. So whether it's really relevant or not is a good question. Yeah, consider it a proxy for social support. That's exactly what I was going to say. Yeah, social support, probably socioeconomic status too, because married people tend to, have more income and be at a more stable point in life. Not always, but at least for young married people. But it's complicated picking a reference group. So some people just avoid the issue altogether and use the US reference group. I do have an updated reference group for up to 2014, 2016. I published a set of reference groups. So those are better than to use than this one. but for some kinds of data quality reasons, it might be better to really to make your own state reference group or even a local reference group if you have a big city. If you are a big city. Calculating excess rates is just subtraction. And really, you just take and the Bill's example from Alaska is interesting because you have the Alaska rates were pretty low in the maternal health and prematurity risk period. Not a large Black population here. That's part of what contributes to it. So, but very low birth weight babies is not a big problem with death in Alaska. So you take each period's rate, subtract the reference group rate, and come up with the difference. And the difference is the excess mortality rate. This is an estimate of preventability. I like to say this here because when you're using vital records data, you can't really tell whether an individual death was preventable or not, but that is hugely important. It's really important to know which deaths and which causes are preventable causes. And the vital records data doesn't help us with that a lot, so we use this as a way to estimate preventability at the population level. So excess mortality means preventable births in general, not at the individual level. Tanaya, you go ahead and talk.
So maybe you're going to get to this, but you mentioned it, like Alaska is demographically different. And I'll vouch for that because I worked there for 2 years. Um, and so would it be in like part two where you also mentioned, well, there's not a lot of African Americans in Alaska, so that explains, the good numbers. And I mentioned that because Washington State, where I'm at, the moms tend to be older. And I kind of wonder like, well, and I guess if I'm, you know, creating it like this, you could see where it would be like, the excess rate is part of maternal health and um our moms are just older, and kind of seeing where that excess rate is. So I guess the question is, I kind of rambled a bit, but are we going to get to that, trying to explain some of these differences compared to the reference group? Thank you.
Well, yes, we are, but not today because that's really phase 2 analysis. But you're right, there really are differences across the country. Things are not the same. But you notice about Alaska here, 3.1 is their infant health death rate, and probably a lot of factors go into this. But 3.1 is extremely high. The USA reference population here has 0.8 as their infant health rate. More current reference group is more like 0.5. So very high infant health risk period. And remember, these babies are born at more than 1,500 grams. They survive their first month. They go home. What's Alaska like? It's hugely rural. There's really problems with access to healthcare. So if a baby gets a cold or gets pneumonia or something like that, then they can die from that in Alaska. There's also a lot of problems with safe infant sleep in Alaska. But these are problems that you would figure this out in the phase 2 analysis. For now, what we're focusing on is kind of the distribution across those colored boxes. And so you can see that in Alaska, which is way different from a lot of other places, no neighborhood ED in AK. Can you do your
Oh yeah, I was gonna say, yeah, like we always see ED use really high with infants. That makes sense, particularly for first time parents. And but if you're in Alaska and like you were mentioning, like upper respiratory infection, there's usually a clinic in a village, but there is no emergency departments, no. Yeah, you're gonna have to take a plane, maybe several planes.
yeah, yeah. And a lot of times in some season, winter, you can't do anything. I mean, in Alaska, when a woman's going to give birth, I think they move her to Anchorage at 2
Yep.
months before delivery or something like that. And they live in dorm type situation.
Mm-hmm.
waiting to
Yeah, and
have
it,
it.
it used to be that the mom
Mm.
would come by herself, but recently, when I was there, they allowed someone to come with her. I just can't imagine just being all by myself in a
Yeah.
huge town like Anchorage, when I'm from a small village of like maybe 100 people, to
And
just
like,
wait it
who's
out.
going to come with her and who's going to stay home and take care of
Mm-hmm.
the other kids?
Yeah.
This is so complicated. But, but anyway,
Sorry, I could
at
talk
this
about
stage,
forever.
okay, at this stage, we really care about which box is the most, which box is the highest. And here, obviously, it's clear that we need to focus on the infant health risk period in Alaska. So what do we do next is the question. We can do subpopulation analysis. So because there were enough numbers to do white, Alaska Native, and compare each of those to this national reference group, we can figure out this is just the rates. But then we need to do excess mortality. So subtract the external reference group rate from each of those, and you get really a more detailed picture of what's going on in Alaska. With 6.3 being the rate for infant health for among the native population. And that really tells you what's going on. It's a little bit high. I mean, the infant health population for the white population, the infant health risk period is also a little bit high. Other places that are a little bit high, newborn care risk period. So this would be babies that are, a lot of times these are babies that die in the first day I mentioned, or they're always in the first month, but they're oftentimes still at the hospital. They might be babies that need to be in the NICU. And we might have a little problem with NICU care quality here, because notice that the newborn care period rate is the excess mortality is 0 for white people and 1 for Alaska Natives. So we might have a issue in inequitable newborn care. But we need to not just take this we need to do the phase 2 analysis to look at this. Okay, so Fa asks, you mentioned that reference groups are available online. They are published. I can send you the article so you can get them easily. 2 questions. Can you point us to where we can find it? It was published in Maternal and Child Health Journal in 2021. If the time period we want to analyze isn't the same as the reference group, is it possible to recalculate reference groups? It's kind of hard to make reference groups. I mean, you should investigate making your own reference group. A lot of times, I mean, a USA reference group is not going to change very fast. We are a slow moving ship. We don't probably it won't have changed very much at all since the one that I published in 2021. But and plus you might want to look at trends in excess mortality, and you don't want to change reference groups every year. So some people end up using the national reference group for a long time, as they did in Alaska. And this article, I think, was published in the early 20 teens or something. I don't remember exactly, maybe 10 years ago. But the reference group was old at the point that they published this. A disadvantage of using this reference group is that it does change. And sometimes you want one that stays the same. So to use the example on the screen, your reference group is 2004 and 2004, but 3 and 4, but we wanted to do 5 years. Could I use that reference group for my study? Yes, you can use an old reference group that has different years in it, in smaller number of years. The point is, if it's a large reference group like the national one, it won't change much. So yes, you can use it for your study. I would give it some thought. It's not always the right thing. If you can make a local one, you might want to. You're welcome. Now, calculating the excess number of deaths is sort of a back calculation to do. And it's a way to sort of translate the excess rate into something real that people can hang on to. So all you do is take the excess mortality rate multiply it by the denominator for that population. So the 20,000 denominator for whites in Alaska, and then you get 3 excess deaths. And for Alaska Natives, the denominator is different, and you get 70 excess deaths. Good question. I've had problems on whether the comparison group was calculated in the same year. Yeah, if it's not calculated in the same year, it may be questionable for the community to understand. So this isn't a decision there. Hopefully you can make this decision with your community, the decision of what reference group. Any questions about this back calculation to calculate the excess number of deaths? A lot of times this is a easier number to deal with because we can say to the community things like, well, this is a whole, this is 2 classrooms worth of kids or something like that. It's just easier for people to understand than rates. But I think you'll have the slides, and so you can check those calculations. But this is makes a little bit of a different picture. That when you translate it into number of deaths, excess number of deaths, it becomes more a picture of what is the burden for the state, the overall contribution to mortality for the state, translating it on like a level playing field. So the excess number of deaths is useful for that. And still, for Alaska Natives, the infant health period is a big gap, no matter which way you look at it. Sometimes the excess number of deaths will be different. Like in Nebraska, we're majority white. And when we translate to excess number of deaths, white people still get prioritized according to the numbers. So the PPOR analysis gives you a lot of numbers, a lot of things that you can look at. You need to pick and choose what you're going to share with who. Hopefully you have a small group of people who can come along with you and really understand this and ask you questions and criticize your work and help you get better. Like, which reference group should we really use? That kind of question. Or why did you do this or that? But the public does not need to see all these numbers. You should work out, messaging to the public should be very simple, very small bunch of numbers. I mean, like 2 or 3 numbers most. Pa, you had another question?
Yeah, I just wanted to make a comment also, especially when using
Ooh, I
racial groups.
can't hear you. You got very quiet.
Oh, I see. Can you hear me better now?
A little bit. Let me see if I can turn up my volume too.
Yeah. Sorry about that. But I was going to comment that if you're going to use racial groups for comparison, the other important thing is to make sure that that your definitions or how you are grouping people in those buckets follow the same way that the reference group is being put in those buckets. And if not, then to make a point to mention that in your comments on the methodology, because for instance, especially for the other and missing groups, there's a lot of people with background, like mixed backgrounds that can fall into the other missing groups, but they're actually like Alaska Native and they have access to all the Alaska Native, services and conditions of living. They just so happen to not fall into in the Alaska Native bucket because they're also white or they're also black. So if you're going to use those comparisons, to pay attention to definition of like how people are being placed in those buckets is also important to compare apples to apples, I suppose.
You do what the community expects you to do. Do what makes sense to the community. Yes, I agree with you completely. It's a great question. And one of the things that we need to do, especially when we have a small population, but Alaska Natives are probably this way too, but a lot of times, see that other category, that 3rd row there, a lot of times people who are making the tables for the public or doing the analysis will group everybody who's mixed race. Everyone who checked more than one box will go into this other. And you can see here that there's not all that many people in that box, or at least not all that many deaths. But who are they? In a lot of states, Native Americans are the people who are most likely to check more than one box. So they would come out in that other box, and their numbers are so small of the people who just check the Native American box that if you take all the people who checked more than one box and checked Native American was one of their boxes, you can double the population of Native Americans. And the community itself considers all these people to be Native American. I mean, they are the people who show up at powwows or something, you know, if that is the case, if people who are mixed race consider themselves and the community considers them to be part of the Native American community, then they should be counted as Native Americans and not as other. And it can make a huge difference when the populations are, they're a minority population, that's a small population. I think that sort of gets at what you're talking about, but yeah, it should be, your work should be aligned with how the community thinks of itself. There is a new census guideline for race. Well, the census has been for a long time allowing people to check multiple boxes, but they did add a new category, right? The North African, Middle Eastern category is a new category for the census. And maybe what you're referring to, Bob. If you want to explain more, that's okay. Yeah, new OMB category. Right. Let's keep going. But anyway, this picture and the picture before of the excess rates, those are different for different places. And so it's worth making these things yourself. How you want to communicate it to the community is a different question. So this is an example of what they would do if they had an internal comparison group. Yeah, OMB, not census. But everybody will adopt those OMB categories. Those will get trickled into all our data systems. But right now, we have pretty good data for those people who check multiple boxes. And we can even do it on CDC Wonder. We can pull out those multiple box people and count them in whatever category they really belong, according to what our community thinks. Okay, going on to a different reference group. This is very small numbers. Total number of deaths is 42, and this is realistic, y'all. If you're making an internal reference group, you've gotta check this. Don't count on being able to use an internal reference group. They're 20 or more years of age, 13 or more years of education, white, and residents of Alaska. Very small group of high education people. So we wouldn't really want to make rates based on that. For those of you who have a statistics background, you know that if you have one random variable subtracted from another random variable, you calculate their standard deviation of that difference. You have to add the two variances together and take the square root. So if either one of them has a big standard deviation, like that reference group that has small numbers, it makes the differences have huge variance as well. So we want reference groups that are large. We want reference groups that are large because it makes the standard deviations of those counts, those rates, small. We want small standard deviations when we're going to take a difference because it just multiplies the uncertainty effect, and you don't want a lot of uncertainty. You want precision if possible. So it's really a balance, trying to figure out a reference group. Oh, good. The link to the OMB policy. It's good to have that. So PPOR has limitations, and hopefully I've been bringing up some of them along the way, but probably not. This has been too much raw stuff, but we do have limitations that we need to talk about. The small number of deaths is a problem because a lot of times we want to focus on a particular subpopulation in our county. And if they have small numbers, PPOR isn't really going to help you a whole lot. The variances are going to be too wide, the confidence intervals are going to be too wide, and you're gonna have mushy information that isn't really helping you. It does take time, and you are mostly EPIs and you're probably busy, and the EPI time is part of it. It's just part of it. if you get experience with vital records, it's not that much time. There's nothing really, you can see already that there's nothing super complicated about it. But by the time you deal with all the data quality issues and all the questions, it takes time. But the biggest part of the time investment is having that community committee that's on board with you, communicating with them effectively, doing the back and forth that you really need to make good decisions about your analysis, what is, assumptions about who to group together and who belongs together, all that stuff is important. Teaching the stakeholders what they need to know to understand the data, and yeah, learning from the stakeholders, learning from all the stakeholders. I don't know how many of you guys have experience with working with groups of stakeholders, but oftentimes there is a loud voice, a voice of authority that tends to speak for the group. And it's difficult to get stakeholders who are from different perspectives and different education levels and different amounts of authority to speak out and give their expertise. And that whole process takes time, and it's very helpful if the data person can be there, that this is not just program people. Different ways of communicating. Data quality problems can cause bias, and you need to be aware of that. In some cases, you can predict what the bias is going to be. You can do sensitivity analyses with your PPOR data to say, well, if this missing data goes one way, it's going to tell us this. If it goes the other way, it's going to tell us that. Are these two messages really different? That's a sensitivity analysis. Are they going to point us in the different directions? It doesn't need to be super technical. What you need to know is what should you do? Where should you focus? And for that, if you have data quality problems, you can test their impact by doing sensitivity analysis before you make your decisions. And again, all that stuff is really hard to communicate to the lay audience that's going to have to actually make the decision. But you need to do that behind the scenes work and then tell them what the real answers are. Always tell them what you know and tell them what you don't know. Tell them, be transparent about that. It's important to not go around telling people all the problems with the data, because usually the problems are small enough that you can still get good information out of it, right? So, but you need to be transparent about it. And these last ones, number 4 and number 5 here, are important. The vital records data, it is really limited. I mean, there are 100 variables or more than 100 variables on vital records. So it asks a lot of questions. It has a lot of information, but there's a whole bunch of information that it does not have. It doesn't get at why the mom didn't do prenatal care. It doesn't get at even where she got prenatal care. There's a whole bunch of questions that are really important as far as decision making goes. And vital records doesn't have all that nuance in there. And so you need to supplement it. FEMUR is a good way to get that. In FEMUR reviews, fetal infant mortality reviews, you get some community voice. You get the mother telling her story about why this or that happened, why she didn't take the baby to the doctor, or why she had to take the baby to the doctor 2 or 3 times. Those kind of things come out in a FEMUR review, and you get to know what those systems were that actually impacted the mom. And those things can really fill in the gaps that vital records data leaves. Having community voices on that data committee is really important. There's nothing that data can tell you. The data is never going to tell you everything that you can learn from having somebody in the community on your committee, and not just one somebody, but plenty of somebodies. And there's also a lot of population-based data that you can get from other sources. PRAMS data is usually available at the state level, usually not at the local level, but you can still piece together if you're local and you can get PRAMS state data, you can make inferences. You can put together these unrelated puzzle pieces. You don't have to do a full linkage and statistical analysis for everything. Census data is really an important way to get at to get at social determinants of health. And you need to add in that what you know from the peer-reviewed literature. Does this cause that? That's what you get from peer-reviewed literature. By the way, PPOR is not a very good way to do research. There are some research articles about PPOR, this or that aspect of PPOR, but um, PPOR relies on the vital records data, which has its limitations. It's not like a controlled study. You really need to add in that kind of information from the peer-reviewed literature. At this point, it's probably good to talk about, the real benefits of PPOR, other than just what you guys as EPIs like. Part of what you want to do with PPOR, part of the benefit is building that data capacity, and not just in you, not just in your EPI staff, but in the community, building up the habit for the community to look at data, and to really understand it, to feel some ownership sense of it. PPOR can do that because it's pretty simple. That's one of the reasons it was kept simple. And phase 2 can also be simple, even though you can use things like adjusted logistic regression and things like that in phase 2. You don't have to. You can keep it simple enough that people can understand it. So since people feel empowered and they have the capacity to understand the numbers, it becomes a way to help the community get better at using data. It also helps strengthen partnerships. One of the people who helped develop PPOR would always say, I mean, she was the local health department leader, and she would say, I have this community, this huge community group that they all want to go different directions. They all think, they each have their own hammer and they think their own nail is the most important thing. And we have trouble going in one direction altogether. And we need PPOR to help us with that. And when PPOR says, you guys have to address this is the most important thing, then the whole big community kind of falls in line behind this. The collective impact model talks about the same thing, that when you have a piece of data that you can follow along over time and the community has agreed to it, it helps you stay on track and it helps everybody work toward the same goal. PPOR, the fourth bucket here, dot here, is the integration with other efforts. And for this, we're talking about Title V needs assessment. The cycle fits in. I mean, a lot of states use Title V. They use PPOR for their Title V needs assessment. It also fits in if you've already got a FEMR process going, which a lot of places do. It can fit in with that. It can add data to the FEMR. One of the problems with FEMR, of course, is that you're only looking at deaths. And people get pretty, people who do those death reviews learn a lot about what things look like to a mom who's had a death, who's, 4 minutes left. I'm talking too long. But they forget that the population of deaths is a lot different from the population of births. And yet, the population that you're going to intervene on is the population of everybody. You can't know who's going to die ahead of time, right? So FEMR is helped by PPOR and the other way around, of course, I already mentioned. Evidence-based interventions, because you know what you need to do. You need to find an intervention that will do that. People believe in data. Some people believe in data more than other things. And so it helps leverage resources and helps get systems to change. I think we're pretty close. Yeah, we're pretty close to the end. So there is time for maybe a few questions. There are any left? You guys have to come back for the phase 2. Everybody stops at phase 1. But you'll like phase 2 also. Feel free to just holler out questions if you want to. We'll put them in the chat. Or arguments. I don't mind arguments. Well, we can send out the slides and the exercise with the answer key. Now, in negotiations with Vital Records since December. Oh, yeah. Well, send out the slides and the answer key and also the article that has the reference groups in case that will help you. Any other homework that we should do? Any other things that you guys need? Sometimes if you can't get Vital Records, you might ask for the processed data. You might want to educate your state Vital Records people on how to do the PPOR analysis. I mean, that is a way to get at some things, and it's not rocket science. Some of them are willing to do it. Texas does PPOR every year. I think they put it out in their Healthy Texas Babies report. They do just the first few steps of PPOR, not the full analysis. But a lot of states are hanging on to that data more than they used to. De-identified data, yeah. And there are statutes. There are statutes that say public health can use this data. And ethically, this data belongs to the people and should be used for the people's health. But there's a lot of arguments that stop us from getting the data. Well, thank you. Thank you. Feel free to email me if you have questions. Couldn't follow how Alaska had excess counts. Less than 10. A negative count, a negative excess mortality just means that the population they're looking at was better, had a better rate, a lower rate than the reference population. For some reason, I can't go backwards on these slides. I don't know why that is. I used to be able to do that. Maybe there's another way. But anyway, that's all it means is the reference population. This does have some SAS code at the end in case you guys use SAS. The logic is translatable easily to other packages. Since I went forward in the slides, let's see the SAS code.
Yes, the slides, exercise, key, and article will be shared out as well as the recording. And I will share that with you. Hopefully tomorrow morning, the recording will be ready and shared out. And Dr. Carol Gilbert will be back with us on November 7th, and you have that calendar hold already for phase 2. And she's available for technical assistance and connecting you all with different sites who already do PPOR. So she sometimes joins us for the training course in the summer, and then sometimes she does these trainings. So just depends on the year. But thank you all for joining. I'll be in Minneapolis at APHA this weekend, next week. If you're there, I'd love to say hello, but thank you for being here.
You are, and you're welcome for those of you saying thanks. Bye-bye.